will discuss MSK spotters in this video. This is the set 2. You can check out set 1 on our YouTube channel. We'll discuss 10 spotters. Each spotter will be displayed for 30 seconds. Answers will be discussed after each spotter. This was a hand and skull x-ray of mucopolysaccharidosis case. And in that, it's Hurler syndrome because there's classic J-shaped cella which is pathognomic. There's macrocephaly, frontal bossing with small facial bones. In hand, we can see proximally pointed metacarpals, which is a feature of mucopolysaccharidosis in general. There is osteopenia. And detailed imaging review video of mucopolysaccharidosis is on our page. You can check out the video. This is a case of diaphyseal achalasis, also known as hereditary multiple exhaustosis. The features are in its name. The multiple exhaustosis or osteochondromas, which are pointing away from the joint, are present. They are bilateral and symmetrical, and there is positive family history. Skeletal dysplasia case, it's cleidocranial dysplasia. Cleido means clavicle, so there is absent or hypoplastic clavicle involving most commonly the lateral half. There are supernumerary ribs and small superiorly spaced scapulae. And cranial means skull, so there are multiple vermian bones, premature closure of sutures. There can be supranumerary teeth and frontal bossing which can be seen. Another skeletal dysplasia, osteogenesis imperfecta. We can see severe osteoporosis and deformed gracile bones, especially the long bones. There's thinned out cortex. Pathological fractures at different stages of healing are present. This is pathognomic for imperfecta, and callus formation is present in fracture sites. Case of congenital block vertebra, here we can see two fused vertebra congenitally will show wasp or waist sign, that is narrowing of their joint. This is absent in acquired block vertebra in cases of spinal infections, etc. This is Camurati Engelmann disease, also called as progressive diaphyseal dysplasia. There is fusiform dilatation or enlargement of diaphysis especially, and there can be associated sclerosis. There is epiphyseal sparing. That means epiphysis is normal in such cases. Multiple variable sized lytic lesions in the calvaria involving almost all the calvarial bones. So the diagnosis will be calvarial metastasis. Differential diagnosis is multiple myeloma cases in which almost similar sized lytic lesions will be present. This case was giant cell tumor. First of all, we can see it's a mature skeleton. There's closed growth plate, so that it is not ABC or aneurysmal bone cyst. In giant cell tumor, we have a lytic lesion, epiphyseal, with non-sclerotic margin, thinned out cortex, and trabeculae will be present. There will be no matrix mineralization. Here we have a case of chondromyxoid fibroma. There is a lobulated eccentric lesion with long axis parallel to the axis of bone. Sclerotic margins are present, trabeculations are present. There is pathological fracture also in this case. There won't be any periosteal reaction or matrix mineralization. Differential diagnosis for these cases will be non-ossifying fibroma. This was a case of fibrous dysplasia involving the calvarial bone, parietal bone in this case. There is well-defined lytic lesion on X-ray with sclerotic margin, that is called rind sign, and there is ground glass appearance very well seen on CT images. For more such videos and exam related content, follow our page on YouTube and Instagram at Radiology Doodles.